So it's going. I want to review a little bit about what we did yesterday. I know some people got confused with the drawing and everything. I'll simplify it this way and we'll do it one more time real fast. This is just one side of the spinal cord. This is the other. The line in the middle just separates the two sides. Let's look at just pain and temperature and light, touch, and pressure. Those two pathways, where do they cross over? At the spinal cord or up in the medulla? Spinal cord. So let's just say we're just going to take one of them. They both follow the same thing. The only difference is what? Between light, touch, and pressure and pain and temperature. What tract they're in. But everything else is the same. So we have temperature coming in. We have the little ganglion there. I hate this. Now it comes in. And remember, what does it do when it comes in? It synapses, and then what? And then we get the crossover, right? And then when it's here, it goes straight up, right? Let's do the same thing at level T11. Ganglion comes in, goes in, and then works its way up. Same thing here. Crosses over and works its way up. Okay? So all of those cables together represents one tract as it goes up. Let's draw in another color the opposite side. Comes in, goes in, synapses, crosses over, and goes up. And then the last one. And again, all four of those are in one tract together, going all the way up. Okay? 4 cables on each side from the 4 vertebrae, the 4 spinal roots that are coming from. So this is pain and temperature, light, touch, and pressure. They follow the same exact thing. Let's do one more, and let's do, we'll do it in blue. And now we're going to throw in our vibratory sense, proprioception. Where does this cross over? In the medulla. So when it enters the spinal cord, it goes up the same side. So I'm going to do it in blue, and blue will be the vibratory sense. We'll just do it over here. It comes in, again, goes through the ganglion, comes in, and then works its way up. In, ganglion, and goes on the same side. It'll be in a different tract. Obviously, the drawing is weird. Goes in and up. Now, so we have 3 tracks going. Now, let's say we get rid of T10. T10 is now knocked out. No electrical activity can happen. Let's follow the yellow. This is at the level of the injury. Will this signal from T10 get into the space? Nope. So we can get rid of that one. This one, T11. Let's follow the line. Are there any breaks? No. That's going to be okay. What about everything below the lesion on the left side? They're okay. There's no breaks, right? Let's look at the right side now. Let's look at the level of the injury at T10. This pathway. Oh, will this signal at T10 get up to the brain? Nope, so T10 is out. What about T11? Oh, gets blocked. So what about below the lesion on the right? Will anything come from pain and temperature? No. Nope. Out. Now, let's look at vibratory sense. Vibratory sense goes up the same side. So proprioception, position sense on the right. Will I have any problems? Follow the blue. Nope. Proprioception on the opposite side, the ipsilateral side, is okay. Good, 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 good. Now, I didn't draw it in, but if I put in the proprioception vibratory tracts on the left side, when they come in, will they be able to get up? Nope. So, when you have a lesion, you lose vibratory position sense on the same side of the lesion, the ipsilateral side. If I have lesion on the left side of T10, will I have any pain and temperature on the right side going down? So pain and temperature, light touch and pressure are contralateral problems. The lesion is on the left, I lose function on the right. It's the opposite side because the crossover is here. When the crossover is in the medulla, we're way above the lesion. We have strokes. That's where, like, anytime you have an injury to the brain, it's going to be a stroke most of the time. So this is a little summary as far as when we have lesions. We're going to bring this up a lot more next week when we talk about spinal cord injuries with Brown-Séquard and where we lose different senses. So hopefully this kind of cleared that up. Any questions? Yes?
This might be, no, this is dumb, but the top yellow one, like that's the only one of that side that's out.
At the level of the lesion, correct. Okay. So when we go over disorders of the spinal cord, we're going to look at it at the level of the lesion, below the lesion, or above the lesion. Where are you getting deficits? Usually above the lesion, everything's going to be fine because everything's normal. It's looking at the level of the lesion right here at T10, or below the lesion, what are we having problems with? And we'll figure that out as we go. Yes?
This just goes for lower motor neuron lesions, right?
No, this is sensory. This is all sensory.
Oh, okay.
This whole thing is sensory. Now motor, same thing, because if I have T10 knocked out, remember the upper motor and the lower motor, synapse here. So I would have, if I knocked this out, what would happen to my motor nerve, my lower motor neuron leaving this spinal cord? Is it going to work? No. So I would have a lower motor neuron lesion at the level of the spinal cord. But I'm going to do a different color here. Okay, the orange is going to be the motor nerve, and I'll do it thicker. So remember, motor comes down and it crosses over before it synapses. This is the upper motor neuron. Can that signal get past T10? No. So everything below the lesion motor is going to have an upper motor neuron problem because the upper motor neuron stopped at T10 and that upper motor neuron signal will not get past it. So all of those lower motor neurons will work, but nothing is telling it what to do because the upper motor neuron can't get past the lesion. We will go through this in more detail next week as we go through the different hemisections, total sections of the spinal cord. Okay, moving on now to the peripheral nervous system. Again, 12 cranial nerves, 31 spinal nerves, peripheral nerves. This is obviously all of our cranial nerves. All the cranial nerves except which two come out of the brainstem? 1 and 2. Everything else comes out of the brainstem. Obviously, again, repeat anatomy, I think probably lecture 1, all the different vertebrae we have in our spine. Now, we come to our dermatomes. Dermatomes are very important in neurology because it tells us sensory things. So if we see any eruptions along dermatome patterns, again, we know what nerve roots are involved. So when you guys do all your different testing and whatever, if C8 works here, then I know that this nerve is intact all the way back to the brain because you have sensation for pain, temperature, light touch, pressure in your fingertips. So obviously the pathway has to work. And we test all various ones. So knowing the dermatomes is very important for neuro. Mainly comes in with like, what's the biggest one you'll know with dermatome patterns? Shingles. Okay, that's really the only one that really comes along with a band-like pattern. In a dermatome, it's going to be shingles. Then we have peripheral, again, neuromuscular junction, the nerve to the muscle. And what I already said, acetylcholine. Neurotransmitter, we know it's acetylcholine. Here's the muscle itself. We will talk about muscle problems a little bit in this class as it relates to nerves not stimulating them. You'll get a lot more stuff with muscle with Dr. Ovalle with rheumatology and with ortho, but we do a little bit of it here as well. What else is important here? Our DTRs are involved here. Any myopathy or any problem with the muscle itself will cause weakness no matter how much nerve stimulation you give it. If the muscle itself is not going to work, it doesn't matter. So we'll talk about muscles later on. Blood flow. Big things to know about this is the brain gets supplied from two areas, carotid and the vertebrals, and they're on both sides. Obviously, we have our two main carotids going up, but we have two vertebral arteries in the back. And what's the main communicating structure in the brain that allows left and right blood to mix? Circle of Willis. So we're going to have communicating, we have backups. If you think about it, if we only had one vessel going to the right side of your brain, only one vessel going to the left side of your brain, if you occlude that, the whole brain is going to die. We have secondary vessel to help with blood flow when we need it. That's what these vertebrals are for. And you can see as we go up, the vertebrals and the carotids, they start to mix as we go up. And then here's our circle of Willis. Important things to recognize. Again, you guys know I don't give you guys pictures for anatomy, but what major arteries I want you to know: anterior cerebral, posterior cerebral, middle cerebral. These are the main vessels of the brain. And when these vessels get occluded, we know what's going to happen to that person mechanically. How are they going to walk, talk, certain things like that, what's going to be affected because of those three vessels. The middle cerebral is the most important one. This is the one that AFib likes to throw its clots into. And the middle cerebral artery feeds the face and the arms. So that's why people with AFib strokes will come in with half their face will be down, upper body weaknesses and whatnot. So this is another important one to know with regards to perfusion and the different vessels that perfuse them. So posterior is obviously all the back, so your visual stuff. The middle cerebral artery has obviously a very, very big territory. That's why with AFib we're so worried, because a lot of them are going to affect that. And we have our anterior circulation, the more anterior part of the brain. So again, just like you do with EKGs, when you know that you had ST elevation in 2-3 in AVF, you know that's an inferior MI. If they present with weakness in their legs, we know it's an anterior cerebral artery stroke. We know it's the anterior part of the brain that's causing the problems. Okay? And this is another way of looking at it. When they come in with certain problems, if certain things are down, if they have no sensation in their face, may have numbness and tingling in their face as part of a TIA or a worse of a stroke, we know it's the middle cerebral artery that caused that problem to happen. Okay, everyone good on the homunculus and everything? Perfusion is very important. Venous flow. We're going to talk about veins a lot when it comes to different types of hemorrhages and hematomas with injuries when we get to that part of the topics later on. Just realize, obviously, all the CSF also will drain into the venous system and then work its way back into the jugular to get drained, recirculated back in. So don't worry about the vessels so much, but obviously we have them and we'll talk about them more. Protection of our brain, just remember the mnemonic SCALP. This is the order of layers. So the scalp is first, connective tissue, aponeurosis, loose connective tissue, and then your bone, the periosteum. And we have our different meningeal layers. The dura mater is the outermost layer. The arachnoid is the middle layer above that subarachnoid. And the pia mater, which actually covers the brain itself. So it's just a narrow way of looking at it, again, for the different protection of the scalp. The scalp has a lot of blood supply. If you ever nicked your scalp, it bleeds a lot. But it'll stop eventually, but this is a lot of blood supply. Obviously, if you have hair growth, you need blood supply for the hair. And for hair to grow, you need a lot of blood supply, so a lot of blood supply in the scalp. And then obviously here are the meninges and the different layers involved. We've already gone through all that. So when it comes to bleeding, this is why it's very important. Blood between the inner surface of the skull and the dura. Epidural hematoma. An epidural hematoma is mainly going to be arterial blood. If we get blood between the dura and the arachnoid space, that's known as a subdural hematoma. Subdural hematomas are mainly venous blood. So they're slow progressing because venous blood is very slow moving, not a lot of pressure, it doesn't do much, it oozes. But a epidural hematoma with arterial blood under much more pressure, it's going to evolve more rapidly, blood's going to expand faster in that area. The last one is blood below the arachnoid mater. It's called a subarachnoid hemorrhage. And what other liquid is also in this area? CSF is in this area as well. So if we did a lumbar puncture in a patient that you thought had a subarachnoid hemorrhage, what would you expect to see in the CSF fluid? Blood. Perfect. So that's one of the major tests. If you suspect someone has a subdural hematoma or a subarachnoid hemorrhage, lumbar puncture to see if there's any blood there. All right, CSF, what I want you to know about this one, very important, clear, colorless, few cells, and little protein. When we get to meningitis, we're going to go over viral and bacterial meningitis. They have different properties with their CSF. So knowing the normal one will make it knowing which, if you have bacterial or viral, even easier. No protein, there shouldn't be any protein there. There's no viruses. So when you have high protein, it means viruses. Few cells, if you start getting white blood cells, red blood cells, obviously there's an infection or there's bleeding going on. Colorless, if it starts getting a straw color, that's like pus that's in there, or white blood cells causing it to be different colors. Another thing I didn't mention here is, but we'll get to that when we get to like pseudotumor cerebri and idiopathic hypertension, is the pressure of the CSF fluid. There's a thing called an opening pressure. The first time you put it in there, you want to get the pressure coming out of the CSF. If it's under high pressure, that means there's excess fluid in that space. So the opening pressure will become important later on with the CSF fluid. Functions, protects brain, O2, glucose, and other chemicals, and obviously circulates through all that stuff to recycle around the brain and the subarachnoid space. Recycle 3 to 4 times a day. Moving on to the autonomic nervous system. Here's our sympathetic system. Remember, on the sympathetic, we have the side chain ganglion right there. And because of that side chain ganglion, the sympathetic system has very short preganglionic fibers. These are the short fibers. And they have long postganglionic fibers. What is the only neurotransmitter at the ganglion down here? This is always going to be, this is always acetylcholine. What changes is past all that. What's going to happen at the heart? What happens at the lungs, the liver, spleen, those things, the sweat glands? Remember, that's a different one. That is where it changes. But at all the ganglion, it's always going to be acetylcholine. So sympathetic, T1, T2, and release ACH, and most of all the postganglionic ones are always norepinephrine. The receptor changes as far as where does it go to. Parasympathetic system, fibers exit 3, 6, or 7, 9, and 10, and also S2, S4. S2, S4 will become very big in neuro and ortho as well when it comes to like low back pain. That's a lot where it happens. One of the questions, then we'll get to we get in the next lecture today about history and physical, bladder and bowel incontinence. If they have bladder and bowel incontinence, that means that S2, S4 got damaged because the bladder control, sphincter control, remember the alpha receptors for the internal sphincters under sympathetic control, that has to go away to allow everything to open. and cause problems. So if they can or they don't even have any control over it, everything just goes, again, damage to S2, S4. This is the opposite. They don't really have a side chain ganglion. They just have these weird ganglions outside somewhere. So with parasympathetic, they have long pre and short post-ganglionic fibers. So it's just the opposite for parasympathetic versus sympathetic. Last little bit is on neurotransmitters and conduction. So remember, we have that saltatory conduction with these nodes of Ranvier, those little spaces, and that allows for propagation of the action potential to keep it at full strength as it goes over these long distances and keeps the propagation going. Our synaptic cleft, this is for nerve-to-nerve communication. Remember, this action potential comes down the neuron. When it gets to the cleft at the bottom, those terminal boutons, that's where all the calcium channels are. Calcium comes in, what's it going to do? Exocytosis, release all your neurotransmitters, and then it goes to the postsynaptic cleft, where it's going to cause another action potential to happen to cause this signal to continue from nerve to nerve. Okay, this is week 1 of physio. Here's our neuromuscular cleft again. Obviously, this is going to be acetylcholine onto what type of receptors on the skeletal end plate? Nicotinic. Nicotinic is always skeletal muscle. So it's always nicotinic. Okay. So that's what it looks like under a scanning electron microscope. Under 16,000 times magnification, you can see how those nerves wrap around those muscle fibers to cause the thing to happen, contraction. Here's our, again, somatic nervous system under voluntary control with acetylcholine. So let's go over some neurotransmitters. First one is acetylcholine. Across the neuromuscular junction, cholinergic receptors, usually excitatory. All preganglionic neurons, has a role in arousal, attention, and motivation. That's acetylcholine. We have our receptors. Remember, you get your nicotinic and your muscarinic. Okay. I'm not going to go over that much detail. This should be review from Pharm, I know. So remember all the different receptors for acetylcholine. This is anticholinergic syndrome. You've had this before, right? You've seen this? Okay. This is where the Mad Hatter came from Alice in Wonderland, because they used lead all the time and they went crazy. So that's why Mad Hatter. Everything else, it's just a mnemonic. If you don't have to remember this one, you don't want to, but these are all the signs of taking too much anticholinergic drugs. Glutamate. What's special about glutamate? What is this one? Excitatory. Okay. The receptors is NMDA. Okay. Or non-NMDA receptors. NMDA receptors, cerebral cortex, amygdala, basal ganglia. So we talked about this in pathophys, this glutamic acid excitotoxicity. So we said like during like seizures or strokes, the area around the infarct, the damaged area gets hyperexcitable. A lot of glutamate goes crazy and it just burns out the cells around it. So it allows the area, the zone of ischemia to kind of spread because you're overexciting these cells. So some of the drugs that we can give now for people with strokes is we block the glutamate so we don't burn out those cells nearby. Glutamate may also play a role with Alzheimer's disease, causing overstimulation and then burns those out and cause cell death. Some cognitive functions with glutamic acid, and obviously seizures as well with glutamate. Dopamine. L-DOPA is the precursor. We're going to talk about L-DOPA a lot because one of the drugs that we give for people with Parkinson's is an L-DOPA. We give it to them, but we give it in a combo form with another drug called carbidopa. We don't want the dopamine getting converted in the periphery. Dopamine can get sucked up by other tissues and taken away from the brain where you want it. So by giving L-DOPA with another drug, it helps all that L-DOPA get to the brain itself where it can have all its effect. Selective inhibitor reduces muscle contraction, produces arousal, executive function, so dopamine is very important. Most addictive drugs will increase dopamine activity. So again, they're always looking for that dopamine rush, and they start getting more and more violent and more extreme to get that dopamine. Secreted from the substantia nigra, and we'll deal with this a lot more when we get to Parkinson's and movement disorders. And we have receptors in the cerebral cortex. They think that schizophrenia is overstimulation of dopamine receptors. And so you give dopamine antagonists for someone who has a history of schizophrenia. Okay. No? No? Okay. Okay, next one is serotonin, synthesized from tryptophan. Where's tryptophan a lot? They say it's found a lot in, but turkey. That's why people fall asleep after they eat a lot of turkey, because tryptophan goes up, serotonin goes up, makes you sleepy, and you fall asleep. So serotonin levels are controlled by the uptake of tryptophan and the MAOs, the monoamine oxidase. So if we give a drug, monoamine oxidase inhibitor, what's going to happen to your levels of serotonin? Go up. Increase. Because we're inhibiting the breakdown of it. We're inhibiting the enzyme, which breaks down serotonin. So it stays around longer. So that's why one of the drugs you give, you'll learn in behavioral health, are these MAOIs to prevent the breakdown so it stays around longer. It's also found in the GI tract, so maybe there's some link between the food that you eat and the serotonin that's released from the gut for your health. Synthesis of melatonin, that's why, again, with the sleep, melatonin is for the sleep. Appetite, sleep, mood, behavior, a lot of things, contributor of well-being and happiness, so serotonin is very big for that. We have these serotonergic receptors, 5-HT. You'll see this when we get to migraines. Some of the drugs we give for migraines deal with the serotonin. There is a link between serotonin and migraines, and we'll get to that when we get to migraines. So decreased serotonin allows for dilation of blood vessels in the brain. When your vessels dilate, that causes the headaches to happen because more blood, remember, everything is fixed. That's why, what helps really good with a migraine? Caffeine. What is caffeine going to do to your vessels? Constrict them, and then the headache goes away. So you take a Coke from McDonald's and you're good to go. What else? So we give sumatriptan, which is a serotonin receptor agonist, and it helps to abort migraines. I'll get to this a lot more when we get to migraines. And decreased serotonin in gut, maybe that's a link between irritable bowel. Anxiety and impulsive behaviors here, so people with low serotonin have attempted suicide, very dramatic means. Maybe some therapeutic effects of Prozac, which prevents the reuptake of serotonin. So when you guys start getting into drugs, you'll see how different things, yes, it's a neuro, we're in neuro, but we're dealing with psych meds, because they do have an effect. Here you go. Right about now, right? Okay, GABA, this is the inhibitory one. Okay, this slows things down. Very highly concentrated, substantia nigra, so all those subcortical centers. Hypothalamus also has some GABA there. Directly responsible for regulation of muscle tone. It inhibits dopamine production, so the more GABA you have, the less dopamine you're going to have as well. So if you have a decrease in GABA, you get dopamine overproduction because nothing is stopping it. When all this dopamine goes up, we get uncontrolled movements. And that's what's called Huntington's disease. It's a genetic disorder. There used to be no cure for it, but I think in the last year or two, through like CRISPR and genetic and stuff, I think they have found some cures for Huntington's disease. But we'll get to that more when we get to like movement disorders. Also, defects in the GABA inhibitory system are implicated in seizures. Seizures are overactivity. GABA is supposed to slow things down. If you have a defective GABA channel, you can't provide that control, and you can't abort those seizures. Norepinephrine is also a neurotransmitter, postganglionic sympathetic fibers, and comes from the adrenal glands, so on and so forth. Precursor is dopamine that makes norepinephrine. So you see where the dopamine can go. If it gets stuck in the adrenals, it's going to make norepinephrine. We give the L-DOPA. We don't want the L-DOPA to go to the adrenal gland. We need to go to the brain. So by giving it with the combo drug, it prevents the kidneys taking it. Blood-brain barrier, again, keeps the bad stuff out, lets the good stuff, go through so we can get to the brain. We've already gone through this so much before. So when we have ischemia, global anoxia, anything with the brain itself, the brain has no way of storing any energy. That's why brain tissue death happens pretty fast. Neurons will cease functioning within seconds if not given enough glucose and oxygen. Hypoperfusion eventually leads to brain liquefaction and necrosis. Remember all those pictures from patho in the very beginning, that first lecture? We talked about necrosis of the brain. We showed you some pictures of how it can coagulate and whatnot. Some biochemical deficiencies that can cause issues. Vitamin B12, defective myelin formation, degeneration of dorsal columns. So what are they going to lose if the dorsal columns go away? What sensation is the dorsal column? Dorsal columns, vibratory sense, discriminatory touch, and proprioception. The dorsal columns. Spinal thalamic tract, is that a sensory or is that a motor tract? Sensory, spine to the thalamus, spinal thalamic, sensory. Causes some axonal degeneration in the central nervous system. So again, B12 deficiency. Next one, diabetes. Okay, loss of integrity of the nerve fibers. This gives you our neuropathies, the loss of vibratory sense. What's the main consequence with diabetics who have these bad peripheral neuropathies? What can they get? Charcot-foot, gangrene, those issues. Again, due to it's a metabolic problem causing a neuronal deficit. Alcoholism, cerebellar degeneration, and it doesn't come back. I'll show you some pictures later on of alcoholic brain, and you'll see how the cerebellum is like half the size from chronic alcoholism. Okay, take a break. Come back at, what time is it? Yeah, okay, it's only 1:03. Okay, come back at 1:15. Okay, we'll get started. So, with neuro, a lot of the neuro stuff is based off of the history and the physical. So we do spend some time going over history and physical questions because remember, you guys are used to doing OSCEs where you know going in, this is a pulmonary derm case, I know it's a cardiac or a vascular case, you know these things going in, so when you get your complaint, your brain automatically goes to those topics to start thinking of. Now is when you have to start really like looking at a symptom and see what other diseases can cause these symptoms to happen. So you have to start ruling out a lot of things with neuro. So as we go through this lecture, it's kind of going through your normal history and physical as far as what are the things we want to look at from a neuro perspective. So we're just going to just listen and just relax, and we'll just go through it. So first thing, you guys went through this before. Is the patient even reliable? Some of the things we're going to discuss in this class are disorders of consciousness. Are they obtunded? Are they arousable? Can they even talk to you? Do they make any sense? So can they even give you a good history? A lot of the stuff in neuro you're going to get from the family members, especially when they come in with a stroke. They can't give you any history. Especially if they have like Alzheimer's and they're forgetting things. Usually the family members are going to be like, hey, they're not doing this, whatever. You have to get information from the family. Accurate description of the problem is key. So talk to witnesses. Who witnessed the event? If they passed out and had a seizure, was it witnessed? Find out who that person was and call them up and find out if they're not there. What happened when they fell? If they passed out, what are the two things you're worried about? Well, system-wise. Neuro and what's another reason for cardiac? So you got to rule out neuro or cardiac. So the question you want to find out, how did the event happen? What was the prodromal symptoms before they passed out? A witness may help. And then try to answer, is this a neurological disease? Is the problem with this patient, is it the brain? Is it the spinal cord, peripheral nerve, neuromuscular junction, or the muscle? Those are the only things it could be because that's where our nervous system comes into play. So figure it out. Where is the problem coming from? Onset and timing, just like with cardiac, very important with neuro. If it's a slow, sudden onset with slow improvement, suggests a vascular event, a stroke. Sudden onset, slow improvement because it's a vascular problem. If it's a gradual onset, gradual progression, tumors, dementia will be very gradual, doesn't happen all of a sudden. If it exacerbates and remits, what are their symptoms like? Does it come and go? Think of like demyelinating diseases. Multiple sclerosis will have relapses and remission whenever a new plaque forms. Delirium, episodes of delirium, they'll be fine for a while, and then they go delirious again, and they come back and forth. That's an exacerbation and a remittance. And any history of trauma, you're hitting the head, car accident, stuff like that. Always find out those answers. Obviously, what makes it better and what makes it worse? Stress, what precipitates it, especially when it gets to like headaches. Headaches are a neurological problem. You gotta ask questions about their headache. When did it start? What does it feel like? Where's the pain located? Stuff like that. Taking any pain relievers. Does light or noise make your headache worse? Okay, so anyone ever had a migraine, you'll know that lights and noises make things worse. So ask them these questions. Does it come on with reading? Maybe it's like an ocular migraine from reading too much. What makes it better or worse? So find out these questions from your patient. The quality. This is important for headaches. Okay, is it a stabbing pain, like something's taking a pickaxe in my brain? Is it a throbbing pain? Is it one-sided? When it comes to headaches, there's cluster headaches, migraines, tension headaches, different types, and they all have different symptoms based off of how they're presenting. So ask them, what does it feel like? Where is it hurting? Okay, if it's only one side of the head, if you've had migraines, you may only have unilateral headaches, only one side of your head. Is it one side of the body, numbness on the entire limb, stocking glove distribution, that's hands and feet. Diabetic neuropathy has hands and feet, stocking glove distribution, starts in the hands and the feet. So these are the things that are important to know when a patient comes in with neurological problems. Severity, 0 to 10, obviously you all love those 0 to 10 scales. Until they come in with like, I'm tired. And you're like, I don't know, on a scale of 0 to 10, I ask that question. And then you guys get stuck. So, okay, medications and allergies, very important to find out. Pain relievers, any psych meds they're taking. Herbals, okay, herbals do count. You gotta ask them these questions, any street drugs, any allergies and whatnot. Past medical history, surgical history, again, headaches, seizures, trauma, any history of any infections. They had a history of, meningitis in the past, psych disorders, any other neural issues, toxin exposures. So if you're worried about toxin exposure, what's a good question to ask them? What's your job? What do you do? Are they around chemicals all the time? So this is where these questions are important. Social history, obviously, ask about alcohol, tobacco, drug use, education, employment, travel. Support system is at home is very important depending on what they're coming in for. If they have a massive stroke and half their body doesn't work, they can't take care of themselves at home, they need help. Can they go upstairs? Stuff like that. A lot of this stuff you'll get also in geriatrics. A lot of all the issues you'll get focus on that stuff in that class as well. Family history, anyone in your family have any neural symptoms as well, any history of strokes in the family. Migraines are also genetic as well. Psych disorders, obviously age and death, and any neurological problems in the family, Parkinson's, Alzheimer's, those things. Review of systems, general, basically all the same. Weight change is important. Sleep patterns, how are they sleeping? Are they getting enough sleep? Those can all cause issues. Neurological review of systems, any headaches? Have they had witnessed any loss of consciousness? Any speech problems? They can't find the words or they can't get the words out when they're talking to your patient. Memory loss, obviously we'll go through the mini mental status exam in a second. How's their concentration? And disorientation, you hear stories about these people with Alzheimer's and they walk on the street and they're walking, they don't know where they are anymore, and they get lost. Cranial nerves, look for any focal deficits, eye problems, facial numbness, deafness, dysphagia. These are all neurological things. You want to ask your patients, do they have any of these problems? Motor sensory, any paresthesias, radiculopathy, that's referred pain, going down an arm, like sciatic pain going down the leg is radiculopathy. Tremors, weakness, any involuntary movements where they're twitching or having a tic or something that's going on. Ask them all these questions, what's going on with that patient. Cerebellar problems, any altered coordination, problems with equilibrium, tremors. What do you do? What's your cerebellar testing on your physical exam? Finger to nose. What else is there? Heel, up the shin, rapid alternating movements, walking back and forth. You know, tippy toes, tandem walking on your heels, those are all cerebellar functions. Psych, any anxiety, mood swings, mania, depression. Behavioral health and neuro go together. You'll see a lot of the overlapping diseases. So like I said, you'll get a lot of repetition this semester, really ingraining this stuff. And so if you didn't get it the first time, you're going to get it again. It's okay. Suicidal ideations, always take seriously. Okay. Delusions, hallucinations, any unusual behavior, poor social judgment. Okay. Normally they would know that, yeah, you don't put new clothes in the trash, and they start doing these weird things. This is very important. Must not miss symptoms. These are the big ones. You don't want to miss these because these all relate to very serious complications, which we'll get to throughout the semester. Worst headache of my life, or a thunderclap headache. Subarachnoid hemorrhage. That's what you're worried about there. Sudden blindness. What are you worried about with a sudden onset of a problem? What is that mainly going to be? Vascular, which is stroke. Okay, so remember, sudden onset usually means it's a vascular problem. Sudden onset of chest pain because you have a heart attack. So stuff like that. Back pain worse at night. What do you do at night? You lay down. So when you lay down flat, does the back pain get worse? Yes. That could be underlying for a epidural spinal cord tumor. Because when you lay down at night, it's like the Princess and the Pea. You lay down and you feel the tumor pressing against your spinal cord and it causes pain. You don't want to miss that tumor because they say when it lay down, it hurts more. Bladder and bowel incontinence. What nerve roots are we worried about? S2 to S4. The pudendal nerve is there. Okay? So we're worried about those things with lower back pain, especially like a cauda equini syndrome where they have a lower back pain where they severed it. They may lose bladder and bowel function. And then obviously suicidal ideation with plan. That's one you don't want to miss. You know, so yes, I thought about hurting myself and I have a bottle of Tylenol in my car. That means they actually have a plan to do something. They actually went and bought something. You don't want to miss those things. So let's move on to our focused neuro exam, and we'll just zip through these as we go through. This is another important one to know. This tells you the definition, the condition. So they have a coma. What is a coma? Decreased level of consciousness. And then the structure, a coma is usually non-localizing. It's just usually global. Your whole brain is out. Disorientation. Disorientation is a lack of orientation to time and place. Those are your temporal lobe problems. So what's the very, very first thing you do on a physical exam when you walk into a patient's room? You confirm things, but you're also observing your patient and you're looking at them. If your patient has an appointment for Tuesday at 2:30 and January 9th, whatever today is, 6th, and they show up on time, obviously they're alert to person, place, and time because they showed up where they're supposed to, the right floor, the right time. So already you know they're okay in some respects. But disorientation, what's going on? Amnesia, memory loss, temporal lobe. So again, if they're coming in with these problems, have memory problems, temporal lobe may be the problem. Aphasia, speech problems. This could be the frontal. If it's the frontal, what kind of speech are we talking about? Is it having problem getting the words out or comprehension? Why the words out? Broca's. And Broca's and the motor cortex is in the frontal lobe, right? That's all motor. Temporal parietal lobe is mainly your sensory area. Remember, the postcentral gyrus is in the parietal lobe. So the sensory issues. So speech problem, the temporal parietal, that's your Wernicke's. You can still talk, your motor function still works, but the Wernicke's area, the parietal area is not comprehending anything that you're hearing. Inappropriate affect. Inappropriate emotional display, it's usually a bilateral cerebral damage. Agnosia, inability to recognize objects. So let's say you give a person a pen in the right hand, and they can't recognize it. It's a non-dominant parietal lobe. How do you know what side of your brain is dominant? Handwriting, whatever one in your right hand. So if I'm right-handed, I am left brain dominant. If you're left-handed, you're right brain dominant. A lot of serial killers are left-hand dominant. I don't know why, but they are.
So they're right.
No, they're left-handed. They're right brain dominant. I don't know why. Maybe there's something that's off with the wiring, but they're higher. So in neuro, if they're coming in with something like this, like one side is weaker than the other side, you want to put what dominant hand they are. A 45-year-old right hand dominant male, whatever. Do it all like that. This is why you know. So if I said they're a right-handed person, which means they're left dominant brain. If I can't recognize objects, it's the non-dominant hemisphere, so it's the right side. So if I'm right-handed, my dominant hemisphere is left. So if I have problem, I can't recognize objects, it's my non-dominant parietal lobe. My non-dominant parietal lobe is my right side. Because I'm right-handed, remember, with motor, the left brain controls the right side of your body. So if I'm right-handed, my left brain is dominant. So if you have a non-dominant parietal lobe, it's the non-dominant hemisphere, which would be the right side, or the same side that you write with. If you're ambidextrous, I don't know. Yeah.
Sorry, that's regardless of what hand you put it in? Okay.
And the last one is apraxia, inability to follow orders. On a mini mental status exam, which we'll go through in a second, you're going to have a little piece of paper you're going to give them. And on that paper, it's going to say, fold this paper in half and put it on your right side on the floor. And then you just make sure they do it. So can they follow orders and do things? That's a mental status check as well. Levels of consciousness. This is another one to know. Okay, severely impaired with brainstem damage. So if you have a loss of consciousness, that means that both sides of the brain have to be affected. Because if you only have one side of the brain affected, that's like a seizure, a simple one. You don't lose consciousness, but you have like tics or whatever. So toxins can also cause levels of consciousness. Okay, what's a toxin you've all ingested? Not all of you, but I'll say. Alcohol. And what happens when you eat too much alcohol? You get obtunded, right? Or stuporous. Your level of consciousness dips because of the toxin that you ingested. So as you go in order, this gets worse in the severity as you go down. So awake and alert, you're all awake and alert right now. Lethargic. You're awake, but you fall asleep easy. So if I left you alone, you'd fall asleep. I wake you up, hey, get up. You wake up and be fine, then you go right back to sleep again. That's lethargic. Obtunded. Confused and difficult to arouse. So you're really shaking someone, hey, wake up, they get up and they don't know what's going on, but they'll be aroused, but they're confused. Stuporous, will arouse with painful stimuli. What are some examples of painful stimuli we can give someone? Sternal rub is one. Pen on your nail bed and just push down. Okay, it hurts, but they will wake up if they have pain. If their brain is alert to pain, they will arouse. That's stuporous. They'll arouse with painful stimuli. And then finally is comatose, and they will not arouse to even painful stimuli. The connection won't work, they won't arouse. That's a coma. So those are the 5 stages of consciousness. General exam, vital signs, look for a facial rash, dermatomyositis, it's a helical, a butterfly rash on the face. Palpate the skull, again, looking for any trauma to the skull. Temporal artery, what are you worried about with that one? Giant cell arteritis, so you palpate that as well. Carotid bruits, what are you listening for with a bruit? Turbulence. If you have turbulence, what does that mean you have in the vessel? Obstruction, plaque buildup. Remember, plaques are not uniform, so they cause obstruction of flow, and you hear noise. If you have very high bruits, means you have a lot of plaque. What is risk of happening to those plaques? They can break, and if they break, where are they going? Causing a stroke. So you listen for those things. Palpate the sinuses, progressive sinuses. If someone's coming with headaches, oh, I'm a really bad headache, and you just palpate, oh, it hurts more when I do that. I mean, probably sinusitis is causing the facial pain that causes you to have a headache. Okay. And then obviously cardiovascular. What are we worried about? Atrial fibrillation. So look for your murmurs, look for the rhythm, and so forth. Mental status exam. Okay, observe the general appearance and behavior of your patient. How are they talking to you? Do they make sense? Are they having flight of ideas where they go from one topic to the other and they just keep going? Can they only get out one-word responses? Yes or no? That's why we want you to ask open-ended questions on your physical exam. Don't just ask, is the sky blue? Yes. Well, anyone can say yes. You can say, ask them to describe the color of the sky. See what they do. Mood and affective response, like how is their mood? Are they alert? Are they happy, whatnot? Content of the thought, the sensorium, are they aware of everything around them? And then finally, our mini mental status exam. So behavior, how do they look like? What's their appearance like? Are they taking care of themselves? Okay, are their clothes cleaned? Hair, are they presentable to go out in public? Remember we talked about how some people have hemispatial neglect, where they'll only groom one side of their body. So those are the things that you look for. Excessive grooming, like OCD. Are they washing their hands 30 times a day? One-sided grooming, again, cortex lesion. How's their speech, their mood? Are depressed? Are they very angry, mad all the time? Content of thought, are they having any hallucinations, obsessions? Sensorium, again, and this is where you start asking your question, which you've already done some of these already. Memory, recent and remote. You do serial sevens, person, place, and time, so you do those things already. These are the extra ones that we add in. So this is the mini mental status exam. What I want you to know before we go into detail, this is the major thing. 30 points total. 24 is the magic number. If they're less than 24, they have altered mental status. If they're between 24 and 30, they're okay. So these are the questions we ask, and you'll do this on the behavioral health simulation. You'll go through all this. So what year is it, the season, where are we now? Do your items, count backwards from 100 or count world backwards. Repeat the 3 objects or the 3 things. Show them 2 simple objects, a pen, a watch, whatever it is. Repeat the phrase, no ifs, ands, or buts. That looks at motor function of the mouth to make sure that all the words can be taken out, pronounced effectively. Here is the new ones. Take the paper in your right hand, fold it in half. So are they following directions? Can they follow directions appropriately? Read this and do what it says. So again, are they able to comprehend what they're reading and do the action provided? Next thing, you're going to ask them to make up a sentence and write it about anything. Did the sentence make sense? You know, is it normal structure of a sentence? Is it normally how it will look? And then finally, here is your interlocking pentagons. So can they draw that object? And it'll all be on that paper. You don't have to memorize this. It'll all be on that paper for you. But this is what a mini mental status exam is in total. You only do the first half quickly in PD. Now we do the bottom part. Speech, can they talk? Do they have any problems with the speech? Dysphonia is difficulty producing voice sounds. Aphasia is unable to produce speech. So Broca's aphasia. Dysarthria is difficulty in articulating individual sounds. So no ifs, ands, or buts kind of knocks out all the different sounds that you can get out. Is it fluent? And then there's that phrase. So again, open-ended questions. Why are you here today? What brings you in today? Ask those type of questions. Wernicke's aphasia is known as a receptive aphasia. They can form the words, but there's no content, there's no comprehension behind what they're talking about. Patient is unaware. So they'll be talking and they'll just keep talking. They're not making any sense, but they're having a conversation with you. But they're not aware. Broca's, they're aware, and it's very frustrating for the Broca's patients because they are aware of the condition. They're trying to get these words out, and they get very frustrated. So you can see on the bottom there what they would say. Broca's is expressive aphasia. You just can't express the words because you have the motor problem. Unable to produce words. They are aware of this deficit. So what happens is they can't give you full sentences. They'll just give you a couple of key words that they can get out when you ask them a question. Cranial nerves, optic 2, 3, 4, and 6. So you're kind of doing these things as well, looking at different conditions. Here's cranial nerves 5, 7, 9, 10, 11, the brachiomotor. So looking at tongue deviation, you do your whole accessory motor, turn your head to the side. Special sensory, your olfactory, taste, and auditory. We don't do taste, but you do smell, and you do auditory to make sure that those work. Your motor exams, you do your whole dance, and you have them follow along and make sure they can do it with you. You're looking for atrophy, fasciculations, as you start examining the muscle groups. Look at the tone. Are they having spasms? Are they very rigid? When you have them move their arms, are they like very, very slow, like almost like a cogwheel, like a click, 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 trying to do things? So remember, 5 out of 5 is full strength, and it goes down from there. Sensory exam, you do your pinprick, sharp, dull. Important thing on the pinprick, sharp, and dull, and those of you who I've had in the OSCE, I've told you this, you have to use the same size material. So if you use like a pen that's sharp with a pinpoint, try and find something else that's not sharp that's roughly the same size. Remember, we have all different types of sensory in our fingertips, not just light, touch, and pressure, but pain and temperature. And if you're doing pain as being sharp, but your dull is a bigger area, I'm going to sense a bigger area is being indented for the dull, and I can trick you in lying. Oh yeah, I don't feel anything. Oh, that's sharp, that's dull. Because it's a bigger area. So try and find things that are roughly the same size for sharp and dull so you don't trick your patient. 2-point discriminations here, all these fun things for sensory for your dermatomes. Pain and temperature, remember spinal thalamic, position, sense, vibration, your posterior dorsal white columns, let's remember those where they go. Light touch does do a little bit of both, but for our class, we're mainly going to focus on light touch and pressure also being spinal thalamic as well. Compare symmetrically, always important. If they're coming with right-sided weakness, which side do you examine first? Left. Always the normal side first, and then you look at the weak side for comparison. Here's your 2-point discrimination. We'll get to this a lot more when it comes to like diabetics. Diabetics are good at doing these things because you want to see how far apart before they start sensing 2 points. And that shows the significance of their neuropathy and how bad it's gotten when that gets worse. Your DTRs, remember 2 out of 4 DTR is normal. 3 and 4 are hyperreflexic. 1 and 0 are hyporeflexic. So on an exam, if I say this person has an upper motor neuron lesion, and I say, what would you expect to see on DTR? Is it going to be worse, better, or the same? So here's your DTR. Okay, so here's your answer. Hyperreflexia, upper motor neuron. So that's your hyperreflexia. So 3 out of 4, 4 out of 4 reflexes may be indicative of a upper motor neuron lesion. So now we're getting into these fun little areas. You're going to have to do those for ortho as well, because this goes to the nerve roots and when you start getting problems. So what are we talking about here? We're saying that for C5 nerve root, the motor is the deltoid. So if they're weak in C5, are they going to be able to raise their shoulder? Probably. No. So you see how physical exam, oh, you have problem with raising your shoulder. That's the deltoid. You may have a problem with C5. That's how you can figure out, work backwards where the lesions are. The reflex is your biceps tendon. So C5 is your tendon, and see how that works. Sensation for C5 is along here. I really want you to know these things. So if I say they have this problem, what nerve root, and you're going to get this in ortho as well. You have a question?
If there's an issue with C5, would they have all of the, like, would they not be able to lift their arm, also not have a reflex? Like,
Well, it'll be diminished. I don't say it'll be absent, but it'll be weaker than normal. C6, wrist extension. So if they can't extend their wrist, that's a C6 problem. They may have problems there. Brachioradialis is the tendon involved for that one. C7, wrist flexion. Okay, and that's your triceps tendon. C8, finger flexion. There's no reflex for it, but finger flexion. So again, you see how if they come in with certain complaints, if you know the anatomy and the nerve roots, you can figure out, okay, where is this problem starting? And then if you know, okay, fine, C5, C6, C7, that's our, brachial plexus, is a huge bundle of nerves there. Let's start examining this area that may be the culprit for what's causing the problems with this patient. So that's C8. Peripheral nerve, we'll get to this a lot more detail when we get to peripheral neuropathies. So like carpal tunnel syndrome is purple, your median nerve. There's your purple for the median nerve. So when people have carpal tunnel syndrome, that's where they're going to have the pain in that area. That's why these nerve roots are so important, because if you know, oh, my pinky, my ring finger on this hand don't work very well. Well, if you know what nerve root does those muscles, then you work your way backwards and you can figure out where the issue is. Sensory landmarks, I always pick T10 for injuries because it's the umbilicus, it's easy to remember. That's why, but remember T4 is also the nipple line. L4, foot inversion and your patellar tendon reflex. Okay. L5, extensor digitorum longus. There really is no reflex for that one. But again, can they lift their toes up? If they can't, think L5. S1, peroneus longus and brevis. This is your Achilles. Okay, so those were the normal reflexes and with their nerve roots. These are the brain reflexes I mentioned yesterday, that we have other types of reflexes. And they are pathways between the brain and the part where you do the stimulus. So when you do your abdominal reflex, the upper abdomen is T8, T9. So you do your upper from the umbilicus out. If it's above the umbilicus, T8, T9. Below the umbilicus, T11, T12. And a normal response, twitching of the umbilicus towards the quadrant stimulated. So if you scratch the upper right quadrant, the umbilicus should twitch towards that quadrant. If it doesn't, upper motor neuron lesion is suspected. So remember, these are brain that has to go from the sensory up to the brain, and the brain has to send the signal back down to have that occur. Here's the cremasteric reflex. This is only used on males because it's a testicular rise, and we do it on the male exams when we have those. L1, L2, normal response, stroke the inner thigh, and you'll get elevation of the ipsilateral testicle. So if you stroke the right side, the testicle should rise a little bit on the right side, and the same thing on the left. But again, if they have a suspected upper motor neuron lesion, you may have it. The response will disappear with an upper motor neuron lesion. So this is the cremasteric reflex. Here's the anal wink. This is S2 to S4. Pricking the skin around the anus causes a quick twitch-like constriction of the sphincter. So again, people are brain dead and you're just going to see if they have any brain activity. These are the things that you would do to try to get some responses. Used when patients have suspected sacral or, again, cauda equini syndrome or lesions. Again, the S2, S4 is a big area down there, and it can cause problems. Here's our Babinski reflex. Normal reaction is for great toe to flex, so it goes down. If toe extension implies they have an upper motor neuron lesion. Dorsiflexion of the big toe and fanning is also a positive Babinski's. So babies have a positive Babinski's at first. So when we have Peds Day, hopefully we'll have some young babies, and you can see that and do that, and you see their toes go up. And positive means we have a lesion in the cortical spinal tract, again, upper motor neuron lesions. Clonus. Okay, you guys do clonus in the legs, in the foot. Okay, no one does it here, but if you ever see people that rock in a chair, that's clonus. If they're rocking, it's like a normal tremor. It's nothing bad. But some people just have it just from sitting for a long period of time. They start rocking in the chair. So that quick stretch, slight pressure. So when you dorsiflex the foot and you pull it up real fast and hold it, that's the quick response, and you'll feel it. Tap once is okay. If it starts bouncing, that's not okay. So one clonic jerk is okay, but if you're having multiple clonus activity, repetitive oscillating movement, it's not good. So again, symptom of cortical spinal disease, interruption in your pyramid tract, so those upper motor neurons. Pronator drift, upper motor neuron weakness. Remember, you have your hands up, close your eyes, and just have one go down. Okay, so that's an upper motor neuron lesion if you see pronator drift. Also, verification of internal consistency. People will fake illnesses to get results. This is the way to test if they're faking you or not, because they should have, if they have a real upper motor neuron problem, every time you do that test, it's going to fall every time. Watch them repeatedly. Do they do the same thing every time? They're not going to. That means they're faking. So that's why you watch the face when you palpate the belly. You look for guarding on their belly, on their face. And when you push on the belly, do they wince? Do they retract? Do they pull away? If not, the pain wasn't that bad. So watch the face. So here's pronator drift, and then upper motor lesion on the contralateral side. So if I have pronator drift on the right, the problem is on the left side of the brain because the left side controls the right side of the body. The upper motor neuron on the left side, that one neuron will go all the way down, break off, and go to my arm to allow me to hold it up, and then when it's damaged, that neuron won't work, it falls. Here's our cerebellar testing, muscle contractions, and maintains posture. So again, finger to nose, heel to shin, and your rapid alternating movements. Dysdiadokinesis is the inability to perform those rapidly alternating movements. You'll see it with multiple sclerosis in adults and tumors in the kids. So those are the things that we do. Our gait testing, see if they have an ataxia or incoordination or an intention tremor. So test their gait, toes, heels, walking in tandem, all that fun stuff. Note the amount of arm swinging as well. Normal people, when we walk, our arms are going to sway as we walk for balance. People who have like Parkinson's, they'll walk and their arms are straight. They don't sway at all. They're very straight. So look at the arm swing as they walk. Notice things, whatnot. Walking on heels, test dorsiflexion weakness. Can they keep their heels up? And if their foot keeps falling and they try and do that, that's foot drop. That is a follow that nerve root all the way up and you figure out what the problem is. Walking on toes is good for plantar flexion weakness. And any abnormalities can be due to alcohol, weakness, poor position sense, vertigo, and any leg tremors. So obviously alcohol, always come in, always ask your patient, have you been drinking tonight? And whatnot, if they're coming in with these type of problems. So the cause of the gait must be excluded before you just say, oh, they have a cerebellar lesion or they have a problem. You have to rule out everything else. So make sure they're not drunk, check the alcohol level, B12 levels, all that fun stuff to make sure that there's no other reason to be causing this patient to have this problem. Most elderly people will have difficulty with tandem gait. That's just a normal consequence of aging and neuronal loss. And then again, in geriatrics, you go through this a lot more detail to figure out, is this a problem or not? The unconscious patient, the easiest ones. Looks good from the door and you walk away because there's nothing else you can do. You can't talk to the patient, you can't do anything. So just talk to the nurse, get the vitals and do your exam and walk out. So obviously it's a modified version because they're not alert. They can't respond to you. You can't say, lift your arm for me. They're not going to do it. So if they are comatose, obviously brainstem level or above. That's where the problem is. Comas is always brainstem or the brain itself, not spinal cord issues, peripheral nerves don't cause comas, brain and brainstem. The goal, is the coma due to a structural lesion or a metabolic derangement? Maybe they overdosed on drugs and now they're severely comatose. It's not a structural problem. They just wait for the drug to get out of their system and then they'll wake up again. So you got to figure out, is this metabolic, is it structural, or is it both? So causes of a coma, there's a mnemonic called game times. So the G's, glucose, they can come with a glucose of 27 and be in a coma, or the opposite. Remember all the diabetic ketoacidosis? Glucose is 400, 500, but they're still in a coma or obtunded. A is anoxia, acidosis, your alcohol. Again, things that can cause comas. M, medications, most common one. E, your electrolytes or the environment. So obviously if you fall into a frozen lake, you're going to come out of that not alert, but your body may be frozen and warm you up and see what happens. Tumors for the T, toxins. Eyes, your infections, meningitis can cause comatose and so forth, encephalitis. The other M is your metabolic. Diabetes is already listed. E, epilepsy, and then S for your stroke or any psych one. So these are just an easy way to remember different causes of a coma. So for the unconscious patient, think, is this an intracranial problem that's causing them to be in a coma? Your job, again, when you get to a hospital level is why are they in the hospital and get them out as fast as possible. Is this a toxic metabolic problem that's causing them to be in a coma? Lack of oxygen to the brain, do they have a stroke and that caused issues to happen? Were they suffocating and lack of oxygen to the brain? Those things too. Ischemic, psych issues. In other words, head trauma, seizure, diabetes, your basic things when you ask in a history and present illness. Why are they here? These are the questions you want to ask to rule in or rule out other causes for a coma. No one just comes in with a coma. There has to be a reason for it. And your job, and these are the reasons where it could be. So structural, any difference between left and right side? Anything there? Any abnormal reflexes with the brain stem? That's when you start doing your anal wing. There's another one we'll learn about later called the caloric testing. You put ice water into the ear and you see how the eyes move. If nothing happens, they're brain dead. There's no connection there. If something does happen, there's still activity. Mental status evaluation, again, how are they to all these type of stimuli? Again, when they're in the comatose, they won't arouse to painful stimuli, so try the painful stimuli to see if they wake up. This is important as well. How are they positioned in the bed? So there's two different types of posturing they can have. We kind of mentioned this a little bit in pathophys. Decorticate and decerebrate posturing. They are motor responses indicative of more generalized reflexes. The better prognosis is a decorticate posturing. So if you see someone decorticate, what does that mean? Adduction of the upper arms, flexion of the lower arms, wrist and fingers, extended lower extremities. They'll be like this in bed. This is decorticate posturing. And I'll show you a picture in a second of a football player. If you see them get hit and they're out like this is decerebrate posturing. Arms are extended, arms are extended in this extended pose. This is decerebrate posturing. This is a worse prognosis than the decorticate one. So these are different. So how is your patient positioned in bed? Are they displaying any of these positions? So this is a decorticate injury. He got knocked. Like, you can show Tua Tagovailoa, like 30 of them. Trevor Lawrence got hit last year, and he almost went decerebrate almost. His arm started going out like this a little bit. But again, you see them all the time. Whenever you see someone get hit really hard and you see their hands going like this, and they're shaking, they can't control it, that's a decorticate positioning. There's just another example of what they look like. Glasgow Coma Scale. This tells you how alert your patient is. What do I want you to know? The key number is 8. If they're less than 8, you have to intubate. But what does it also tell me? If best response is 15 and they're 8 or below, what do I have to keep in mind about medications now? No PO. Everything's got to be IV because they can't swallow anything. So less than 8, intubate, and also got to think about how you're going to deliver your medications because they're not going to be able to swallow anything. It's got to be IV or parenteral. So there's a whole big scale here. Yes, there's a whole bunch of numbers, but the key number is 8. If they're 8 or below, they're severely altered. You can't give oral medications and stuff like that. Autonomic nervous system, we mentioned this before. Blood pressure, pupillary response, urinary output, GI function. What patients have autonomic dysfunction? They have alterations of these things. Diabetics. So diabetics have problem with blood pressure. We'll get to diabetics when we get to the eye again. I told you we're coming back to the eye later, but we'll get to it. Cranial nerve 3 palsies. You have pupillary response changes because of diabetes. Urinary output, remember the gastroparesis, everything slows down. So autonomic dysfunction causes the opposite of these problems. First signs of pure autonomic failure, here's your postural hypotension. They get up, they get dizzy. Impotence, that's when a male will go and see the doctor for the first time, is when that stops happening. And when that happens, we already know they're probably further advanced with other problems because that doesn't happen at once. It's usually other places as well. Disturbance of micturition, how they go to the bathroom. Multiple system atrophy. Degeneration may be progressive. And you get different problems from there. And we'll go through all the different diseases as we get through them. So there's our review. So any questions about how to do a history and physical on a patient? It's a lot more involved than your normal ones because as you see as we went through it, a lot of these things can be diagnosed just based off of the physical exam, and then you get your imaging to confirm things. So the lecture we'll start with on Friday is diagnostic imaging from a neuro perspective, and then we'll start into the diseases. Okay? See you guys on Friday.